Welcome to our video on obstructive sleep disorders. Let's begin. Here are the topics we will be covering in this lecture: obstructive sleep apnea, which we will see abbreviated as OSA, and obesity hypoventilation syndrome, also known as Pickwickian syndrome. For each topic, we'll discuss definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management of that disease. Let's first discuss obstructive sleep apnea. Obstructive sleep apnea is defined as intermittent obstruction of the upper airway, typically at the oropharynx, which can lead to periods of apnea or a temporary cessation of breathing during sleep. Now in this lecture, we're discussing obstructive sleep disorders, but you should know that there is also a form of sleep apnea called central sleep apnea. In central sleep apnea, the patient's respiratory effort is impaired, meaning that their brain forgets to send a signal to their respiratory muscles so that they can take a breath. Central sleep apnea can be caused by CNS injury or toxicity, heart failure, and opioids. In obstructive sleep apnea, the periods of apnea can occur multiple times overnight and last from 20 to 30 seconds or even be longer. Due to the blocked airflow during apnea, the patient becomes hypoxic, causing them to wake up to take a breath. Now that we've discussed the definition and pathophysiology of obstructive sleep apnea, let's discuss the risk factors and presentation. The number one major risk factor for obstructive sleep apnea is obesity. In obese patients, the weight from extra tissue at the neck collapses the airway, especially when they are laying down. While this classic patient in test questions is obese, remember that in real life, patients who are not obese can also have obstructive sleep apnea. Other causes of obstructive sleep apnea include structural abnormalities that can block the airway, like adenotonsillar hypertrophy, nasal polyps, or a severe overbite with a small chin. Although obesity is also a major risk factor in children with OSA, adenotonsillar hypertrophy is a classic cause of OSA in children more so than in adults. This diagram can help you visualize the oropharynx and see how those risk factors we just discussed can block the airway. When you breathe in, air enters the nasal cavity, goes down your naropharynx to your oropharynx, and then goes past your larynx to enter your trachea. In the image on the left, the adenoids and tonsils are highlighted so you can see how, if they were to grow bigger, that could block the airway. In the picture on the right, you can see how in an obese patient with excess neck fat, when they lay down, the extra weight from the fat collapses the airway. Now let's discuss the clinical presentation. Loud snoring, especially in test questions, is the number one clue to obstructive sleep apnea. In reality, while snoring has a sensitivity of 80 to 90% for obstructive sleep apnea, its specificity is less than 50%. So in practice, just because someone snores, it does not mean that they have OSA, because the patient might not be aware that they snore. If you have a high suspicion of obstructive sleep apnea, it is helpful to get collaborative information from a partner or family member who can tell you about the patient's sleeping habits. Due to disrupted sleep, many patients will complain of daytime sleepiness, difficulty concentrating, headache, or fatigue. Any patient who falls asleep while driving should be evaluated for sleep disorders, including obstructive sleep apnea. This is especially true for commercial truck drivers since they drive large vehicles and work long hours. Repeated hypoxemia from apneic episodes can lead to several changes in the patient's heart and vasculature. Hypoxia can trigger the sympathetic nervous system and increase levels of circulating catecholamines, contributing to systemic hypertension. Hypoxia can also constrict the pulmonary vasculature, resulting in pulmonary hypertension. Eventually, the right ventricle can fail from having to pump blood against the pulmonary hypertension, which is known as cor pulmonale. Lastly, heart cells can become irritated from the hypoxia, leading to development of cardiac arrhythmias. Let's review a question. What effect will hypoxia have on the CBC of an obstructive sleep apnea patient? We know that the OSA patient's apneic episodes will lead to hypoxia, which will in turn mean that each red blood cell will carry less oxygen. This decrease in oxygen will be sensed by the kidney and will trigger the kidneys to release erythropoietin. Erythropoietin will then stimulate the bone marrow, causing it to produce more red blood cells. This is a review of Step 1 physiology, so if you'd like a refresher, see our physiology chapter. So in answer to the question, a patient's CBC will show an increased red blood cell count or erythrocytosis. Now that we've discussed the clinical presentation and risk factors of obstructive sleep apnea, let's discuss diagnosis and management. The diagnosis of OSA is made by polysomnography or an overnight sleep study. The severity of a patient's OSA is based on the number of respiratory-related disturbances they experience in a given hour of sleep. Here you see a man undergoing polysomnography. The monitors attached to him track brain activity, oxygen and carbon dioxide levels, vital signs, snoring, and movement. Now let's discuss management of OSA patients. It's important to counsel all OSA patients to avoid substances like alcohol and sedatives, since these can relax the airways and increase likelihood of airway collapse. In patients whose OSA is likely secondary to obesity, weight loss can be encouraged. If the patient's OSA is determined to be mild after polysomnography, then the patient can see if they notice any improvement when sleeping on their side, since that can improve airflow to the lungs. For severe cases of OSA, management is with nocturnal CPAP or continuous positive airway pressure that is administered while the patient is asleep. Here's an illustration of a patient using CPAP machine while they sleep. As its name suggests, the machine provides continuous positive pressure into the patient's nasal cavity, and this pressure prevents collapse of the upper pharynx. Although this is the preferred therapy in OSA patients, many patients do not like to use the machine due to its noise and discomfort. So whenever you have a OSA patient who is supposed to be on a CPAP, don't assume they are compliant with treatment and always ask if they actually use their CPAP machine at night. If patient's OSA is due to structural abnormality, they can receive a custom oral mouthpiece to improve airflow. In the case of OSA secondary to excess oropharyngeal tissue, patients can undergo a procedure known as uvulopalato-pharyngeoplasty in order to remove that extra tissue. Finally, tracheostomy is performed as a last resort if the patient has failed all other therapies and they are experiencing life-threatening complications. The next topic we will discuss is obesity hypoventilation syndrome, also known as Pickwickian syndrome. From here on, you will see obesity hypoventilation syndrome abbreviated as OHS. Obesity hypoventilation syndrome is daytime hypercapnia or a PaCO2 of greater than 45 in an obese patient, defined as BMI of greater than 30. OHS and OSA are not mutually exclusive, and many OHS patients also have OSA. The key difference between OSA and OHS, however, is that OSA patients have transient hypoxia and hypercapnia that resolves on waking. They do not have daytime hypercapnia. In obesity hypoventilation syndrome, excess thoracic tissue compresses the thoracic cavity. This physical restriction of the thoracic cavity reduces chest wall and lung compliance. The decreased compliance in turn increases total airway resistance, leading to decreased tidal volume, or the amount of air that moves in or out of the lungs with one respiratory cycle, and decreased total lung capacity. Carbon dioxide therefore begins to accumulate in the patient's lungs at night, and the persistent physical restriction makes it difficult to exhale excess carbon dioxide during the day. It then becomes more and more difficult to maintain normal capnia, since the patient needs higher than normal levels of respiratory drive. What is the acid-base status of a patient with OHS? We just discussed how OHS patients have daytime hypercapnia due to accumulated carbon dioxide. Since this carbon dioxide builds up due to a problem with the lungs and it happens over a long period of time, the patient therefore has a chronic respiratory acidosis. But this is not the final answer. If you recall from step 1, a chronic acid-base status is often compensated. Let's use this diagram to continue answering our acid-base status question. On the left, we have shown how excess tissue restricts the thoracic cavity. The lungs have a difficult time expanding, which leads to carbon dioxide retention and a chronic respiratory acidosis. Now, since our initial acid-base status change is from the respiratory system, the compensation has to occur in the metabolic system. The process for this compensation occurs at the intercalated cells in the collecting duct of a nephron. The kidneys try to maintain a normal pH by increasing bicarbonate retention and decreasing chloride reabsorption. How does the kidney do this? As you can see in our simplified diagram on the right, intercalated cells have a bicarbonate chloride exchanger. By using this exchanger, the kidney can make sure that more bicarbonate is transferred back into the blood while chloride is taken out. Therefore, the final acid-base status of OHS patients is a chronic respiratory acidosis with a compensatory metabolic alkalosis. Now, normally we have a hypercapnic respiratory drive, meaning that we increase our breathing in response to more carbon dioxide. As carbon dioxide accumulates in OHS patients, however, their brainstem is instead stimulated to breathe by hypoxia instead of hypercapnia. This is further exacerbated by metabolic alkalosis, which decreases the respiratory drive to carbon dioxide and contributes to overall hypoventilation. In summary, OHS patients can't breathe due to excess weight causing lung restriction, and won't breathe due to decreased chemosensitivity to hypercapnia from their persistent nocturnal hypoventilation. Now that we have reviewed the definition and pathophysiology of OHS, let's now discuss the risk factors and clinical presentation of the disease. Not surprisingly, the major risk factor for obesity hypoventilation is obesity, and in particular, severe obesity or a BMI of greater than 50. Now let's discuss clinical presentation of OHS. Due to persistent lung restriction, patients with OHS might present with dyspnea or trouble breathing. Just like OSA patients, they might also develop pulmonary hypertension leading to cor pulmonale and erythrocytosis due to hypoxemia. And like we discussed, their acid-base status will reveal a chronic respiratory acidosis with a compensatory metabolic alkalosis. Now let's wrap up by discussing the diagnosis and management of OHS. In order to diagnose a patient with OHS, they have to meet 3 main criteria. They must have a BMI of greater than 30, have daytime hypercapnia defined as PaCO2 over 45 on arterial blood gas, and have no alternative explanation for their hypoventilation so a chest X-ray should be obtained to rule out any pulmonary disease. Nocturnal monitoring of carbon dioxide on polysomnography is also part of the gold standard of diagnosis of OHS and can aid in determining comorbid OSA. Finally, although not required for diagnosis, on pulmonary function tests, these patients should display a restrictive pattern due to physical restriction of their thoracic cavity. You should know, though, that a normal pulmonary function test would not exclude OHS. The management of OHS is similar to OSA. Avoid depressants like alcohol and sedatives that can relax the airways, consider weight loss, and use a nocturnal CPAP machine. Again, considered first-line treatment, with a tracheostomy as one of the last resort options. The only potential different step in management is the use of a respiratory stimulant like acetazolamide, which would also be a last resort. How does acetazolamide work as a respiratory stimulant? The key to the role of acetazolamide in OHS is to consider the acid-base status of these patients. They have a chronic respiratory acidosis, but more importantly, they then have a compensatory metabolic alkalosis that can reduce their response to hypercapnia. If you recall from pharmacology, acetazolamide is a reversible inhibitor of carbonic anhydrase that works at the proximal convoluted tubule of the nephron. Carbonic anhydrase is responsible for the conversion of carbon dioxide to bicarbonate. So by blocking carbonic anhydrase, acetazolamide effectively increases carbon dioxide levels. This reverses the compensatory metabolic alkalosis with a metabolic acidosis. In turn, the worsening acidosis increases the respiratory drive by increasing chemosensitivity to hypercapnia. Let's wrap up this section with a question. A 60-year-old man presents to the clinic with several months of exertional dyspnea. He states that he can only walk a couple blocks before he feels tired. He also notes that he has been waking up gasping for air in the middle of the night and that he has been increasingly sleepy during the day. Blood pressure is 153/90, pulse is 84, BMI is 52. On exam, JVD is difficult to assess due to neck fat. Heart sounds are distant, bilateral lungs are clear, and bilateral pitting edema is present. Chest X-ray shows no abnormalities. Which of the following diagnostic tests would help confirm the diagnosis? A. Echocardiogram, B. Polysomnography, C. ABG, or D. ABG plus polysomnography. So the patient is presented with exertional dyspnea for a few months. He also states that he has been waking up short of breath in the middle of the night and that he has been sleepy during the day. He is hypertensive, has a BMI of 52 with excessive neck fat, has distant heart sounds and bilateral pitting edema, and bilateral lungs are clear on auscultation with a chest X-ray that shows no abnormalities. His excessive neck fat and sleep disturbances are suggestive of OSA, but his BMI is greater than 50 and is concerning for OHS, especially in the setting of exertional dyspnea with likely cor pulmonale given his distant heart sounds and pitting edema. Therefore, since we are concerned not just for OSA, but for comorbid OHS, we should get polysomnography to evaluate his nighttime sleep disturbances and an arterial blood gas to confirm daytime hypercapnia. So the correct answer is D, ABG plus polysomnography. While polysomnography will be helpful to evaluate for both OHS and OSA, since there is concern for OHS in our patient, we must make sure that we obtain an arterial blood gas. Recall from our discussion on the diagnosis of OHS that the key differentiator between OHS and OSA is hypercapnia, indicated by a PaCO2 of greater than 45 on ABG. A is wrong, because while we do have concern for cor pulmonale, which should be evaluated by echo, the underlying cause of his exertional dyspnea is likely OHS, which could not be confirmed by echo. B is wrong, because while polysomnography alone is sufficient to diagnose OSA, in order to meet criteria for OHS, he must also show daytime hypercapnia on ABG. C is wrong, because while ABG would confirm daytime hypercapnia, this is by itself not enough to diagnose OHS. Polysomnography with nocturnal CO2 monitoring is also part of the gold standard OHS evaluation and is needed to evaluate for comorbid OSA. And that concludes this section.